also we have another workshop face-to-face just 2 weeks ago at College of Medicine, University of Baghdad, moderated by Dr. Mudar Khairullah. And thankfully, Dr. Wathik, Dr. Zainab, and their colleagues from the UK volunteered to have an online session in order to make life easier to you and enable you to pass, inshallah, the PACES examination in the future. These activities are part of the program of the RCP Iraq network for the 2023. And hopefully in the future, we talked with Dr. Zainab, is that we will have another sessions regarding preparation for part 1 and part 2 as well, so that the candidate will be oriented from the start and they can plan for their career in the future. May I introduce now to you Dr. Wathik Mahmood. He's registrars in nephrology working in the UK. Dr. Wathik will take us in a journey for 2 hours tonight, and there will be tips and tricks on how to pass the PACES examination. Dr. Wathik, thank you very much for your time and effort, and definitely we will enjoy your session today. And the floor is yours, Dr. Wathik.
So thank you, Dr. Hilal. Assalamu alaikum jami'an. So we will start now. So I'll talk about a few things in terms of history taking. I will pinpoint a few avoidable mistakes. And if you know that in terms of history taking in PACES exam, at the moment, it takes about 14 minutes, 12 minutes to take history, and then the exam.
Dr. Wathik, are you with us? Sorry for that. I think there is a disconnected Dr. Wathik. He is now back again. Dr. Wathik, the mic is muted.
Yes, yeah.
Okay.
Do you hear me now? Yeah.
Yes, audible.
So yeah.
Go ahead, please.
Yes. So in terms of history taking, as you know, it's 12 minutes, and then the examiners at the end of 12 minutes will warn you that you have only 2 minutes. So you need to address the concerns of the patients, as you know, and then they will ask you for different questions depending on the case scenario for 5 minutes to assess your evaluation for the case. So now I'll talk not only about history taking, I'll say a few things about the technique of the exam. I will mention a few examples. For instance, when you present, even in a clinical examination, when you present about the case and the examiner would ask you, how would you investigate this gentleman? And by the way, it's better to call the patient gentleman or lady, not the patient. Much better, more humane, to be honest. So if the examiner asks you about how would you investigate? For example, if the patient, you suspected pulmonary fibrosis and you would say, I would like to do like a blood test. It's very important not just to enumerate investigations. Do not say like full blood count and chest x-ray and CT scan. You need to mention in details why you are asking for these tests, like a blood test or a radiological test specifically. You need to say why I am asking for full blood count, like looking for something like leukocytosis, anemia, whatever, depends on the case. And for example, as I have mentioned, if you said this patient most likely at the top of the list, my differential diagnosis would include pulmonary fibrosis, and the examiner would ask you, how would you investigate the patient? You would say CT scan, and then the examiner would say to you, which kind of CT scan? Then you say high resolution CT scan. This called the prompting, which is not good for your score. You need to say, I would like to ask for bloods, looking for something. I would like to ask for high resolution CT scan to look for something. It depends on this like potential pulmonary fibrosis. So you need to elaborate your answer, not just saying a few words. At this stage, any questions? Is it clear? So first of all, avoid any prompting from the examiner. The second of all, you need to do practice constantly, so you will be able to show self-confidence, which is like real self-confidence based on good practice and good knowledge, not deluded self-confidence. So if you, because as you know, practice makes perfect. If you do practice like daily or every 2-3 days, so you will be having good attention span, will be able to do the 2 hours of the exam in a good way, as you know. So avoid the prompting. The second of all, do practice so you will avoid something sometimes could be embarrassing, as you know, mumbling when you say something, like you spend 30 minutes in the exam and then you feel tired and they are asking you every 10-20 minutes, they are asking you repeatedly different questions, and there's no rest, like you take rest just to focus on the case, and they will ask you, and then you are tired after 30-50 minutes, for example, and then you will lose your ability to speak confidently and loudly, and then they call it mumbling. You will say, like, they cannot understand what you are saying because you are tired. So what you need to do practice, avoid mumbling by doing the practice. Like if you are running 2 miles or 2 kilos, and the exam will be running off 10 kilos, the lack of practice will be very obvious in the exam. So avoid mumbling. Do not wait for prompting to say, because you might know the answer, but you are not practicing saying these details. That's why you are waiting for them to say to you which kind of blood test, which kind of CT scan, which kind of like whatever, like renal biopsy, whatever the tests. Even in communication with the patient, if you are talking about, for example, breaking bad news, as you know, in terms of breaking bad news, you need to use a special technique. Like I would mention a few things like warning shots. If you are going to say to the patient, you are having terminal illness like cancer, and you are saying to him, I would like, sorry, I've got some bad news to tell you. This is called warning shot. So you have to use all these things without waiting for prompting from the examiners, which is very good for your score. And the third thing is very important. Do not invent signs in a clinical examination or history taking or communication. If there is no splenomegaly, say there is. If you are not, as they say, if you don't know, don't go. If you are not entirely sure, don't say. And I can't elicit splenomegaly, for example. Or if you cannot hear audible murmur clearly, say I can't hear audible murmur. Like on this gentleman, on examining this gentleman. Say that. It's better than missing the sign. Inventing sign better than Yeah, I'm inventing sign worse than missing a clinical sign. For now, this is like general talk about the exam or pinpoint a few avoidable mistakes. So in terms of history taking, before starting in the 3 different scenarios, in terms of history taking, you need to use the techniques of history taking. For example, you need to use open-ended questions, as you know, like when you meet the patient, as you know, you need to introduce yourself, take consent, saying who are you, why you are here. My name is somebody, I'm one of the medical doctors, I've been asked to speak to you. Is that okay? So by that, you are taking the consent from the patient and confirm the name of the patient. And as I have said, your role, and then you need to start by like open-ended questions and then close questions. As you know, in terms of open-ended questions, I assume you know all these things, but just a quick recap for these things. So you need to say, how can I help you? I understand that you've got something. So how can I help you? And the patient will start talking about his situation. And then it depends on the situation, you will elicit more details by going through like systematic review, past medical history, drug history, social history, and family history. And every one of these, there are like box should be ticked if you are talking about history of present illness, a complaint. The patient will say what his situation, and you need to ask about things and mention important negatives depending on the scenario, and then the past medical history, past surgical history. In terms of past medical history, as you know, you need to ask about many things: diabetes, hypertension, asthma, malignancy, past surgical history and previous operations, as you know. And then in terms of drug history, you need to ask about medications. And in terms of PACES exam, you need to, they don't use the drugs, because drugs mean something else, not medications. So you say, are you on any regular medications? And if he or she is on, you need to say, do you take them regularly? Do you take them? And if not, you have to ask why not? Because it could be the lack of communication. The patient doesn't understand the risk and benefit of taking a specific medication. And then in terms of medications, compliance by like taking medications or not, and any herbal remedies, any non-prescription medications, any allergy to any medications. It's very important to ask about allergy. I know you know, but you have to show the examiners that you know. It's your responsibility, because with all due respect to you, the examiners don't know who you are. You have to show them that you know even basic things. You might think these are very basic things. I know them, but they don't know. You are knowing them. You have to show them. And it's your responsibility, even basic, very basic things like, do you have any allergy to any medications? You have to ask. And in terms of like, we are non-native speakers. So because it's only 12 minutes, you need to use specific sentences to ask, especially close questions. Like, you don't have to say, do you have any chest pain? Do you have any, when you talk about chest or cardiac symptoms, you don't have to say, do you have any chest pain? Do you have any palpitation? Do you have any like shortness of breath? Just be quick, especially in station 5. You have to say, you have to practice like saying any chest pain, palpitations, any shortness of breath. Like you have to say them quickly and clearly, and listen to them attentively. Why? Because in English language, as you know, it's different to Arabic language. I would say in English language, listening is active process more than in Arabic language, because they use body language more than in Arabic language. They use like the head nodding, and sometimes in Arabic it could be like interruption, but in English they would say yes, yeah, carry on, go ahead, yes, yeah, I get you. And you have to be like listening attentively to the patient and show the examiners that you are listening. I mean active process, not just like listen, there is no head nodding. Like if the patient saying my father passed away 2 weeks ago, you have to say, I am sorry to hear that. Yeah. You have to show the examiner that you are showing empathy, sympathy with the patient. So at this stage, any questions? No questions. I'll give you a few seconds.
تسمح لي
Yes.
يعني حتى تكون شوية أكثر interactive. Can we repeat in a brief the point that just you have listed?
Yes.
Is that apart from the classical structured history taking, and the way of presenting your skills, your ability is very important.
Yes.
And you stated that you shouldn't wait till the examiner prompts you to clarify a point you have just said, like you exactly as you said, high resolution CT for a patient suspected of having pulmonary. So you know, all teaching previously that in order to get extra mark, don't give the full information from the start and let the examiner ask you another question and you will answer and another question. Now it is the things different now. Beside that, you have to show your sympathy and empathy to the patient, listening very carefully. And apart from that, it is the usual classical structured history taking from any patients in medicine. Regarding the special terms or terminology that use with the patient, you have just highlighted that we should say gentleman or lady rather than
Yes.
this patient and this patient, and this is considered part of humanity and part of professional behavior with the patient. I am right?
Yes, exactly. I would say this exam, special PACES exam, the small details will decide the outcome. Small details, not just enumeration of the investigation. Every small detail will count. So yeah, it's all about small details of every communication or knowledge, everything. You have to practice in terms of the candidates, yes. So if I had a chance to continue, yeah. So now one of the questions about social, yes. So we talked about history of present complaint roughly, and we will talk more in when we practice in the next few minutes. So and then past medical history, past surgical history, and then the drugs. You have a drug history. You have to like name them medications, not drugs, and ask about allergy, ask about herbal remedies, and the compliance, and then the social history. In terms of social history, you need to ask the patient about smoking. And when the patient, and you are saying to the patient, do you smoke? And he or she would say no. You have to ask them, have you ever smoked? And he would say yes. And you need to ask them, when did you quit? Could be just a few days ago. And he was a smoker for like 20, 30 years, as you know. So you have to ask them in details about smoking. For how long, how much did he or she smoked? Did he or she smoke? And then in terms, you have to ask about alcohol, how much and what kind of alcohol, alcohol history. I know in Iraq, it's entirely different story. Like if the patient is female and you want to ask her about alcohol, you have to signpost. You have to say, I'm going to ask personal questions. Is that okay? You have to take consent here. You have to ask sensitively, and you have to change the tone of your voice. You have to change the intonation. Like politely, you have to say, you need to say, I'm going to ask a few personal questions. And there are a few reasons beyond these because it's related to the diagnosis and the treatment of your situation. Is that okay? And the patient should, if you are polite, they would say, even in real life, they would say, yes, yeah, of course, yeah, go ahead. Okay? So social history, smoking, alcohol, and living situation. And you need to ask the patient, who is at home with you? Who is at home with you? Like, is he living in a home, in a house, in apartment, or bungalow? Bungalow, it's a house with just one floor. But because like in Western Europe especially, they have different social system. They need to assess every small detail about the patient. Like if the patient presented with a fall and the toilet and the bathroom is upstairs, so this patient at risk of falling. I'm muted, yeah. Yes. So yeah, you need to ask about the bathroom. Is it upstairs? Is it downstairs? Because if you hear me, if the patient presented with a fall, you have to ask the patient, where is the bathroom at home? Is it just upstairs? Because this patient would be at risk of falling. This is very important part about safety netting. They call it safety netting, like the patient safety outside the hospital, maybe. Okay. So, and in terms of social history, so smoking, alcohol, home situation, occupation is very important. Like if the patient is taxi driver, for example, and presented with a seizure, you have to discuss the driving issue with him or her. Because it's very important. You can't drive and having a seizure and you will be killing 3 or 4 people. Yes, and in terms of pets, you have to, but it depends. Pets, if it's skin rash or cough, the present symptom, you have to ask about any pets at home. What kind of pets is it like? Dogs, cats, whatever you like. You know? But these are the most common pets. Can I check questions?
There is someone who is raising his hand.
Yes.
Please, we need to know who is raising his hand. It is only iPhone. Who is? You can unmute yourself and present yourself, please.
Sorry, sir, it was wrong, but I have a question. My name is Gaylan Sherzad. I'm one of the medical doctors here from Erbil. Okay.
Yes.
My question is that you mentioned that we need to counsel the patient about the driving issues if they present with the seizures. This is just to do it during the history taking or at the end of the history taking to counsel them. Is this a need?
Yes, yeah, you have to counsel them in terms of driving, but different countries have different regulations in terms of driving, as you know, but just raise the issue in the exam. And it depends on the presenting symptom. Is it seizure? Is it TIA? Is it MI? Is it just collapse? Whatever the reason. Is it obstructive sleep apnea? Maybe the patient like sleeping while he's driving. So it depends. Just raise the issue. I don't think there is in Iraq a special, I don't know, to be honest. I'm not entirely sure what's the situation in Iraq, but I don't think there is special regulation to every situation, but just say to the patient, you need to speak to the driving authority, as you know.
Nice.
To ask them what is the regulation in your situation. You might be, you have, And you need to explain to the patient, you sensitively, you have to say to them, I don't know, to be honest, in Iraq, how it, because here, if you are taxi driver and you are saying to the patient, I assume you are not willing to like to hurt yourself or any other people, could be child or a woman or something else, somebody else, but the government here will provide something for this man. If he's not driving, they will give him money. You know, I know how does it work in Iraq, to be honest with you. You are saying to him, do not drive, but you have to suggest something else to him. You have to find occupation to him. I don't know. As I have said to you, in Iraq, in Erbil, I don't know, is the authority able to find another occupation to this man or lady? I don't know.
Yes, yes. Actually, you have done that social support. Sir, thanks a lot for your explanation.
Yeah, thank you. No, not at all. So yeah, and this is social history. And in terms of family history, yeah.
Excuse me.
Yeah.
Hi.
Yeah, go ahead. Yeah.
Sorry for the interruption. My name is Nasim. I'm one of the graduates of Baghdad University College of Medicine. Just to clear some points, there's something called DVLA.
Yes.
It's Driver and Vehicle Licensing Agency. You can read about it for my colleague. It has different regulations for every disease, like for epilepsy or Alzheimer. It's actually the responsibility of the medical caregiver to inform these agencies about if a patient has a certain condition and what he can and cannot do and when he can drive. So DVLA, Driver and Vehicle Licensing Agency, you can look it up, search, and find specifics for every medical condition.
Yes. Well, thank you for your explanation, but this is applicable for people who are doing the exam in the UK. In the UK, they use like in Ireland, they don't have DVLA. In Ireland, which is like very close to, they have the similar system to the UK, but they don't have DVLA. They have different regulations. In Iraq, it's entirely different world. So I don't know how that. So the examiners in Iraq, they might like agree some regulations. I don't know, to be honest. I can't tell you like a specific answer about how does it work in Iraq. But yeah, I would say yes, there is DVLA. There is a like specific circumstances and specific duration to how to stop driving and what to do. Yes, yeah.
I think we have to go, and then there are other questions, Dr. Wathik, but I think the time to go to keep in strict with our schedule.
Okay, perfect. If you give me 1 minute, just 1 minute. In terms of family history, you have to ask about family history and any like similar conditions. And it depends, like if the patient has got a few suspects, for example, polycystic kidney disease. In history taking or session 5, you have to ask about any family history of cerebral hemorrhage. It's very important. Excuse me. And when this is about family history and ask about like father, mother, and parents and siblings, any children, all these things, and do not forget concerns of the patient. It's very important. Like it depends on the patient. Different people have different concerns. Yeah, so we have finished the first 30 minutes. We need to start. So who is the first volunteer?
We have Dr. Rand.
Yes.
Dr. Rand.
Yes, hello, good evening.
Hello, good evening. So I would say short scenario, and you would be acting like in an exam.
Okay.
That's okay?
Yes.
So Mr. Muhammad, his age is 52, presented with left arm weakness for about 2 hours. Presented to you, please assess him. Take your time, take 5 minutes, plan your history taking plan, and then we will start. Is that okay?
Yes,
So
I'm
take-
sorry, he presented to where?
With left
No, not complaint, the place.
to acute medical unit.
Okay.
Okay, today presented to you in acute medical units. His
Mhm.
age only 52, and you have to assess him, or you need to assess him. Take
Okay.
your time. You have 5 minutes. Like
Okay.
in the exam, it would be like that. 5 minutes, plan what you are going to ask, and
Okay.
is that okay? So yeah, I'm waiting for you.
All right.
You can answer other questions, Dr. Wathik, while
Yes,
Dr. Aran prepare
I'm
her
checking.
our
Yeah.
plan. Dr. Nasim, who is moderator with us, can refer to the
Doctor,
question, please.
yes, Dr.
Yes,
Aram
yeah,
Dr. Aram is having a couple of questions. First, have they changed the format of the PACES following the COVID pandemic? Do the stations include phone conversations with the patients or relatives? Another question is, do the stations include simulated man or women? And are the scenarios where the candidates needs to interact with other healthcare professionals like colleagues and nurse, etc.? Or all the stations are
Can we take
patient-oriented?
them question by question?
Yes,
So first question, I don't think they have changed it because of COVID. I don't think so, but they will change it. It's like part of their regulations. They keep changing exams format always. So I think they will change it by end of this year. The second question, can you repeat the second question,
Yes.
please? If you don't,
Second question, do the stations include phone conversations with the patients or relatives?
No, not in PACES exam, no. It should be physical, face-to-face communication. There is no phone consultation.
Mhm.
Might be in a lab there is phone, but not PACES exam, no.
Another question is, do the stations include simulated man or women? What does that mean, simulated man?
Do you mean surrogate or like
Yeah.
actors? Yeah, definitely, yeah. In station 5 and history taking.
Mhm. And
Yes.
are the stations where the candidates need to interact with other healthcare professionals like colleagues and nurses, or all of them are patient-oriented? Do you need more clarification from Dr. Aram himself? Dr. Aram, if you're with us.
Can you explain to me, Dr. Aram, what do you mean exactly? So I can answer you.
Meanwhile, Dr. Wattar, استاذتنا Dr. Wattar with us, and she's examiner in the MRCP PACES. أستاذة ذكرى عندك تعليق؟
السلام عليكم everyone.
عليكم السلام أستاذة.
Thank you everyone. Thank you Dr. Wathik and for your kind presentation. You are doing this presentation from the point of view that you are a specialist and sat the exam maybe very recently. I am talking as an examiner. I am talking about the station 2, which is the history station, and of course, it carries only 5 skills assessment, and they are all very important. As you said, the details of the history has to be taken carefully. By all means, family history, medication, social, including the pets they have at home, and many other things, including in our place here, if we are suspecting of a rash or something else, we have to ask without hesitation, but politely in a professional way about multi-sex relation and the HIV, which is very important to ask, especially, and it's not limited to those who are with extra marriage relation. It can be from blood transfusion. So these things are very important to take. So this is number 1. History station is very important. And Answering Dr. Aram, I think after the COVID, we returned back to face-to-face examination. There is no virtual and there are no telephone calls or something like this. The third thing is, I think the answer is we are using surrogate as well as real patients. So this is very important to make notice that this exam is mainly patients or surrogate in station 2, 4, and station 5, which can be one real case and the other one can be surrogate, pretending that they have symptoms according to the scenario they are given. Before we go, I know the time is limiting, just to give you a brief thing. In the period of 5 minutes prior to going into the station, the candidate is given instructions in a form of a GP letter saying, you are the doctor, I am referring to you this patient who is in this scenario, 52-year-old gentleman who presented with right or left arm weakness, and I would like you to look at him because I have done certain tests and they are fine, but please give your opinion. So usually in that letter, there is, I want the candidate to be very careful. In that letter, there is a hint and information, enough information to direct the candidate into a constructive and a proper history taking according to that scenario. So make sure that in this 5 minutes, the candidate should write notes, and when they go to see the patient, they have this information ready to interact with the patient according to that. So I think at the end of my talk, the exam, yes, it can be difficult, but the examiners are on the side of the candidate. They may drive them back into their way if we find them they are a little bit not on the right track, and it is fair. But as you said, instead of saying HRCT, CT is important because that's what they say, and instead of getting 2 marks in that skill of investigation, they will take only 1, so they will lose some money, some points money. So I think that's very important things. So thank you. I'm going to stop now, and I hope we will carry on with the scenario you are given, and thank you very much for your help.
Thank you so much, Dr. Bikra.
Oh,
Okay,
thank you so much, Dr. Bikra. Thank you so much.
Going back to Dr. Aram, he has clarified his question. He said, I meant by a simulated man, the talking doll or a mannequin.
Yeah, there's no such thing, no. But could
Okay,
be
and then-
like colleagues, maybe, and this depends on the scenario. It could be in ethics, maybe, the ethics station.
Yes, and he's asking another question related to that. He's saying, will be scenarios coming up where the candidates need to handle a challenging situation related to a colleague, such as a drunk colleague or something?
Yes, yeah, it could be, yeah. Could be including such scenarios, yes.
Okay, so we take the final question from Dr. Gaylan, I think, and then we go back to Dr. Rand. Please go ahead, Doctor. iPhone, I think, Dr. Gaylan.
Sorry, Doctor, I have asked my question, previously.
Okay, so...
okay, perfect, yeah. So let's start, yeah.
Yes, hello.
Hello, yes.
Yes, you can start the timer.
Yes, yeah. We'll start now, yeah. Just a few seconds. Bear with me a few seconds.
Yeah, take your time.
12 minutes. Yes, yeah.
Okay,
Yeah, you can start.
Good evening.
Good evening.
I am Dr. Al-Radi, one of the doctors here in the acute medical unit. Am I speaking to Mr. Mohammed, 52 years of age?
Yes, speaking, yeah.
Okay, nice to meet you, Mr. Mohammed.
Nice to meet you.
I am here to ask you questions about your condition so I can possibly help you. Along the consultation, I will be writing some notes. Is that okay with you?
Perfect, yeah.
Okay, so Mr. Mohammed, I can see from your note you are having weakness in your left arm. Is that right?
Yes, yeah.
Okay, can you tell me more about it?
So to be honest with you, yeah, last night at 3 a.m. I woke up and I have noticed that my left arm is heavy. And then when I woke my wife up, she told me that my speech was slurred at the time.
Okay, first of all, I'm sorry to hear that. This must be really difficult for you. I'll try to find what is causing it so I can possibly help you. So you are having this since last night, and you, along with that, you are having a speech problem. Is that right?
Yes, yeah.
Is this the first time you're experiencing such thing?
No, this happened a few days ago, about 5 days ago, but it was only weakness in my arm or heaviness in my arm, which lasted like a few seconds, a few
Okay,
minutes, sorry, in the first one, yeah.
okay. And the second one, for how long did it last?
2 hours.
Okay, 2 hours. Okay, so this weakness, did it start suddenly or gradually?
No, I just woke up.
Okay, so
And I found
suddenly.
that I couldn't move my left arm.
Okay. Do you still have it, or it's completely gone now?
No, I feel now completely normal.
Okay. And what about your speech? Can you tell me more about it?
So what happened? Like I couldn't speak fluently. And my wife raised the issue that my speech was slurred at that moment.
Mm-hmm.
But then, like as you can notice now, I can speak to you normally.
Okay, that's
Yeah.
really good to hear that. And did you have now? Do you have any weakness in anywhere of your body?
No, I feel completely normal at the moment.
Okay. So is there anything that particularly triggered your weakness?
No, I don't know, to be honest. I'm not sure because I just
Okay.
slept and this happened.
Okay.
Then I
And
woke up.
okay, beside the weakness and the speech, slurry speech, do you have any other problems, like any problem with your vision?
No,
Any problem with your sensation? Are you able to feel normally?
oh yes, like you mean no numbness or
Yes,
yeah,
tingling
no,
or numbness.
no,
Okay,
no, no, I feel
okay.
okay.
Do you have any balance problem?
You mean unsteady gait or something like that?
Yes, any balance problem or?
No, but I don't have unsteady gait. I think I'm able to walk as usual.
Okay, any problem with your memory?
No,
Okay,
no,
any abnormal movement like shakiness of your hands, abnormal shakiness?
no,
Any hearing problem? Any ringing in your ears?
no,
Any smell problem?
no,
Any problem with your swallowing, like when you eat or drink food?
no, I swallow as normal. No. I
Okay.
don't have any difficulties in my swallowing.
Okay. So you don't have, apart from your left arm, you don't have any other weakness anywhere in your body? Okay. So do you have any weight change recently?
Weight change.
Yes.
But to be honest with you, I don't weigh myself.
All right. Like, have anyone not told you that you lost some weight or you notice your clothes are getting wider than before?
No, there's no change in the size of my clothes now.
Okay.
Same,
Any
yeah.
headache or dizziness?
At the moment, I don't have headaches, but
Hmm.
occasionally, sometimes, yeah, as everyone, I have a
Okay. Okay.
very occasionally.
Like, do you have especially headache when you suddenly stand up from a seated position?
Headache? No, no.
Okay. Or dizziness? Okay. Do you have any weather preference?
Uh,
Like,
what do you
like
mean Yeah.
Do you feel hot in like normal weather, or do you feel cold?
Do you
More
mean
than normal?
intolerant to
Yes.
hot weather or intolerant to cold? No, as everyone in the house. Yeah. No,
Okay.
there's no
Okay.
exchange. Yeah.
Did you notice any like chest pain?
No.
Any okay. Any racing or pacing of your heart?
Any racing or, sorry, I couldn't hear you.
Any racing or pacing of your heart?
No racing of heart. No.
Okay. And any difficulty breathing?
Shortness of breath. No.
Okay. Do you have any swelling anywhere in your body?
Do you mean lumps or bumps? No. No swelling.
No, just like leg swellings or
I didn't notice any like unusual
Okay.
swelling in my legs. No, to be honest with you.
okay.
I would say no.
Any paleness?
Any pale,
Yes, paleness.
like somebody told me that I'm pale recently.
Yes.
No,
Okay.
I didn't hear that
Okay.
comment from my family. No.
Okay. Any joint pain or muscle pain?
Well, sometimes, yes, I having back pain. Yes.
Okay. Can you tell me more about your back pain?
Well, so to be honest with you, like I'm 52, so yeah, sometimes I am having back pain occasional, like my headaches, as you know.
Okay. And do you have any bowel work like change recently, like any diarrhea or loose stool or constipation?
No. Okay, bowels okay. No.
Okay. How about your water work? Did you notice any change recently in your water work?
No. I'm okay. Yeah, in that respect. Yeah.
I'm sorry to ask this, but have you noticed any loss of control of your bowel work or water work?
No. Well, no.
Okay.
I'm
Any spots or pigmentation or rashes anywhere in your body?
no skin rashes. No.
Okay. Aside from these symptoms, do you like to add something else, maybe?
To be honest, no.
Okay. Okay, Mr. Mohammed, have you been diagnosed with any medical condition in the past?
Yes, I've been told that I have high blood pressure.
Okay.
Yeah.
So can you tell me more about it? Who told you? Did you see a doctor about it?
Yes, my GP told me a few times that my blood pressure is high.
Okay, what was the recording?
I can't remember the readings, to be honest with you, but yeah, he told me that my
Okay.
pressure sometimes is high. Not always, sometimes.
Okay. Did you check it recently?
No, to be honest, I'm very busy, as you know, so I don't have the time to check my blood pressure.
Okay, what was done for your BP? Did he start you on any medication?
What do you mean by BP? I don't.
Sorry, I'm sorry. For your high blood pressure, did he start you on any medication for that?
Well, yes, yeah. He started one of the medications. Yes, I can't remember the name, to be honest with you, but yeah.
Okay.
Yeah.
Do you take your medication regularly as prescribed?
Well, to be honest with you, no.
Okay.
Yes, yeah.
Is there a particular reason that you are not taking your medication regularly?
Yeah, very good question. To be honest with you, I feel okay. So I don't like without this medication, I can't function normally. So why I would take this medication? Because as you know, there are many side effects. I have read about this medication in Google.
All right.
Yeah. So I'm not entirely or totally convinced to take this medication.
Okay, I will check your medication for you and I will advise you accordingly. Aside from high blood pressure, have you been diagnosed with any medical condition like with your heart or with your nerves or with your muscles?
No.
Okay. And aside from this blood pressure medication, do you take any other medication, including over-the-counter medication or herbal remedies?
Yeah, sometimes, yeah, I take some painkillers to my back pain and headaches occasionally.
Okay. What can you tell me what kind of painkillers are you taking?
Oh, to be quite honest with you, I don't know the names. I'm just going to the.
Okay.
Yeah.
Okay. I will ask you more about your painkiller. Okay.
Yes,
And have you been hospitalized recently or did any procedure or surgery?
No.
Okay. And can you tell me about your family? What kind of diseases run in your family? Like anything in particular which is related to your muscle or nerves, or sorry, related with muscle or nerves or heart diseases?
Well, my father passed away about 2 weeks ago because of heart attack.
Oh, I'm really sorry to hear that.
Yeah, thanks.
My
Thank you.
condolences.
Yeah, thank you.
Okay. Any other particular family history?
No, my sister is.
Okay. And do you have any allergies I should know about?
Well, nothing that I am aware of. No. I
Okay.
would say no, yeah.
Okay, Mr. Mohammed, I will be asking you questions about your social life. They can seem personal to you, but it's really important for me to know what's going on with you. Is this all right for you?
Yes, you have only 2 minutes now. Yeah. Just to
Okay.
let you know.
So, okay, do you smoke?
No.
That's really great. And do you drink alcohol?
Very occasionally.
Okay, and how is your diet? Do you have balanced diet?
Iraq, as you know. I'm eating, eating meat at 7 in the morning.
Okay, and did you have any injury recently? Any trauma?
What do you mean, like?
Any injury, any trauma?
No.
Okay. Okay, Mr. Mohammed, do you have any idea of what could be the reason of your symptoms?
No, to be honest, I feel completely normal. So yeah,
Okay.
I would say, shall I go home now? What shall I do? I
Okay.
don't know. Oh, yeah. But my wife told me go to the hospital, go to the hospital. That's why here.
It's really great that you came to the hospital. And is there anything that in particular that is concerning you at the, like mostly now?
Well, to be honest with you, yes, because I want to know what is going on.
Okay.
My main concern, yeah. But if you
Okay.
can't tell me, so I can go home, please.
Okay. So,
Yeah.
Mr. Mohammed, I am suspecting you are having what is called a mini stroke. Have you heard about it?
No.
Okay. So it is a temporary loss of the power of your muscles, which can happen due to a temporary not enough blood going to your brain, to a particular area of your brain. And that time it happens to you 2 times, and both of them affected your speech and your arm. So
Okay.
we are going to run some blood tests and run some scans as well. And we will also start you on some medication, and I will refer you to the nerve doctor as well. Does this sound all right for you?
Who is the nerve doctor? Who is the nerve doctor?
We call him a neurologist. Yes.
What does it mean, a neurologist?
He is a specialist who is he is mostly specialized in for patients with stroke and
Yes.
And starting them on medication. Also, I am going to give you pamphlet and leaflets about your condition, and also
Okay, perfect. Yeah. Yes. Yeah.
and also advise you about physical examination and rehabilitation as well.
Okay. Thank you so much. So
Yes.
now time is up.
Yes.
So I would act as the examiner.
Yes.
If you
Sure.
don't mind. Yeah. So yeah, what do you think? Summarize your history taking.
I'm sorry, I'm supposed to have 1 minute for reflection.
Yes. Yeah. Take that.
Yes.
Because now it's 15 minutes. But yeah.
Okay. Okay.
Take your time. Take your time. Yeah.
The session was very interesting. Really, the attendee asked continually increasing, joining the session. And you can imagine now it is 11 p.m. In Baghdad. So thank you very much for this very interesting session that stimulates many doctors to join and to participate. Thank you very much.
Thank you, Doctor.
Everyone, while Dr. Rand is reflecting on the history, please, you can type your questions down in the chat box and we will address them accordingly. Thank you so much.
So are you ready, Dr. Rand?
Yes, doctor.
Yeah, go ahead. Yeah.
Yes, so Mr. Mohammed, a 52-year-old gentleman, presented with a left arm weakness 2 hours lasted for 2 hours since last night at 3 a.m. Along with that, he also complained of slurred speech, which lasted for the same duration. And this wasn't the first time that has happened to him. It happened to him 5 days ago, and it lasted for a few minutes as well. And he denies any vision problem or balance problem or other neurological symptoms. He was diagnosed with blood pressure, and he is on medication, but he is not compliant with his medication. Along with that, his father has passed of a heart attack, and he is not a smoker. And but his diet is not his diet is not healthy. He's not on a healthy diet.
Yes.
And I couldn't have time to ask about his job and his driving and other important questions due to time limitation.
Yes. So I would like to thank you, because without you, we wouldn't be able to do the teaching. So thank you so much. But do not use excuses because of the limitation of time, because this is the you have to be able to manage your time, you know.
Yes.
You have to be quicker, as I said to you when we started. You asked many questions, which is very good. But you need just to avoid, do you just say, do you have any palpitations or heart racing? Yeah, any chest pain. Just be more systematic. And back to the scenario, what is the risk factors that do you feel in this gentleman?
So yes, my diagnosis is TIA, and he is skipping his blood pressure medication. This is the first risk factor for it. And second one is his diet and also his family history. Maybe he's having underlying heart disease.
Yes, and he is male as well. Yeah?
Exactly, male and over the age of 50.
And when you asked him about smoking, he said to you, no.
I should have asked, did you smoke before?
Yeah, have you ever smoked? He actually smoked for 30 years and did quit just a few days ago. When he has, for example,
Yes, that's.
So he's a smoker, male, more than 50, I would say.
Yeah.
Yes, but hypertensive, could be diabetic, you never know.
Exactly.
Yes. So what would you do for this poor gentleman?
Yes, first I will run some basic blood tests, check his hemoglobin to look for any anemia, could be a sign of weakness, and also check his kidney function test and liver function test since he is on painkillers, and I
So
want
would you like me to interrupt you or make comments when you finish? What would you like?
maybe finish, then
Okay.
so I wouldn't
Okay.
forget the things. So
Yes.
kidney function test and liver function test, because he is on painkillers, so I would like to see how is his kidney and liver is doing.
Okay. Perfect.
And
Yes.
also his cholesterol lipid profile in general, and his blood pressure. I would like to check his blood pressure and his blood sugar as well. And
Yes.
I would like to do a ECG
Yes.
and
Well, yeah.
an echo.
So
And
now I'll prompt you. What would you like to look for in ECG?
basically to look for any arrhythmia that could be the reason for his TIA.
You have to say this.
Yes.
You know this, but do not wait for my prompting.
Yes.
You have to say them. Yeah. Yes.
Yes,
Yeah.
I'm
correct,
sorry.
Yeah. Yes.
And,
No, don't have to be sorry. I'm very good. Yeah.
Yes, and for his TIA, also I want Holter ECG as well
Yes.
to detect any kind of arrhythmia. And
Yes.
I would like to do MRI or CT scan of his brain, and
Yes.
refer him to a neurologist as well, and carotid Doppler as well.
Yes. Yeah,
And
and you have mentioned echo. Yeah.
yes, these are the things that coming to my mind at this moment.
Yeah, very good. Say, but just like classify them as bedside investigations, lab investigations, radiological investigations. You have to be very clear that CT brain, you have to do CT brain. Yeah.
Yes.
Yes. So how would you treat this man now?
First,
Because he wants to go home, this man.
Yes, I would like to admit him, and I will also consult a neurologist
Yes.
to come and check on him, and I will start him on aspirin immediately.
Immediately, or waiting for the CT brain
Yes,
results?
sorry. After ruling out
It could be
any
fatal,
hemorrhage.
by the way, if the patient is having hemorrhage and you are giving him, what is the dose of aspirin and for how long?
It's 300 milligram.
For how long?
For the first 2 weeks.
Perfect. And any specific score you would like to do in assessment of?
Yes, Chad-Vasc score.
If he has got a fib, you mean, but if he doesn't have a fib, any score in terms of TIA, there is like very well known score. Is it ABCD2? Yeah.
Yes, but I heard they don't use it anymore.
No, they use it and they assess the risk, especially in this patient who has had 2 TIAs in 1 week. It's very high risk.
Yes. Yeah.
So yeah, they use it.
Okay.
ABCD2. Yeah.
Okay. Yes.
Yeah. So how would you treat? You would give aspirin and yeah. Okay.
Yes, so from there, accordingly, like if he's having high cholesterol, I would like to check his blood pressure medication and educate him on taking his blood pressure medication. Also,
how would you educate him? How would you explain to him? Because he thinks he's okay, so he doesn't take his medication. What would
I will
say?
tell him that high blood pressure is the main risk factor for his stroke that he's having. So if he is not taking and not controlling his blood pressure regularly, he might develop the full stroke as well. And it can leave him with disability as well.
Yeah, that's very good, but do not intimidate him, to be honest with you. You have to explain the benefit and the risks.
Yes.
If you are taking it would be a very good idea to do this, and don't say you have to, or just say very good idea to take your medication to control blood pressure, as you know, and doing healthy lifestyle, encourage him to walk, to do exercise, to lose, good idea to lose some weight. And there's something called in these countries, if you are doing the exam in the UK or in Western world, they use something called telemetry, if you know. It's like monitoring the heart rates while the patient in a medical ward, they give him
Yes,
some
yes.
kind of
I heard
device.
about it.
Yeah, telemetry, you can read about it and read about, so yeah. So now you are very good, and you missed a few things, which is expected. As you know, we are practicing,
Yes.
not in the exam, but you did very well. So thank you for your help.
Thank
And
you.
if any comment on anyone happy to assess, I would be very happy to listen to you.
I'm sorry, just I have the differential, so it could be TIA and it could be MS maybe.
Yes.
What else it could be?
To be honest with you, it could be like even if TIA and this man who is like a smoker and came in, it could be like due to thromboembolic disease, but it could be malignancy. And you didn't say we need to do chest X-ray for this man, which is very important.
Oh, okay.
Yeah, chest X-ray, it's kind of basic investigation like ECG and bloods.
I try to rule out malignancy by weight loss and anemia and respiratory symptoms.
If you don't have weight loss, this
Okay.
doesn't exclude malignancy, as you know, and
Yes.
every one of our doctors know.
Yeah.
You know, so
Yes.
it doesn't mean that this man doesn't have malignancy, even without weight loss. And when you said I would like to check bloods, renal function, because he was taking, could be non-steroidal anti-inflammatory, you can say yes. And liver function, if I am considering statins, as you know.
Yes.
Yes, so if you are starting him on a statin, you need to know his liver function test.
Yes.
And you didn't ask me about fever, because it could be infective endocarditis, you know?
Yes.
When you ask him any fevers or any high temperature,
they say fever is jargon, so we should ask.
Well, some patients, to be honest, they know fever. And any high temperature, it's okay. You didn't ask me, did you have you lost your consciousness? You asked me about shaking, which is okay.
Yes.
But try to avoid using medical jargons, which is not good in terms of your score. So these are the negatives.
Thank you so much for.
Thank you for your help. Thank you.
Thank you so much, Dr. Rand and Dr. Wathik. So now we go to the discussion, but I guess before we go, we have the next scenario. So can you just give the prompt to Dr. Amir so that we can take our time in the discussion?
So let me find the next scenario.
Just one moment, please. I think Dr. Dikra is raising her hand, and we want to hear her idea as an examiner about the performance and what her advice to Dr. Rand. Please, Dr. Dikra.
مرة ثانية السلام عليكم. It was very interesting scenario and it's very common. As I know, and you know, we are very limited with the time. I am sure practice make perfect. With more practice, the time will be taking all the details in the 12 minutes, which we should have warned Rand to say you have 2 more minutes, and only then she should start asking the patient what is going on and to summarize her history. This is number one. If you are one of the examiner, Dr. Wathik, and you are leading this case and the discussion, what would you have scored Rand on these 5 skills, which is number 1, C, which is the communication and taking the history. Then the differential diagnosis, D, skill D, skill E, F, G. Would you have passed her, or you gave her borderline, or you failed her? What would you give her for communication? I cannot hear you, Dr. Wathik.
I'll be very honest with you, and with Dr. Rand, to be honest with you. So I will fail her because.
Okay.
So do you agree with me?
I have given her some borderlines because she has done good history, although she missed a few important things, and she missed or omitted a few important information in the history, especially the details of the smoking, the family history, the loss of consciousness, a few other things.
Yeah, and she didn't ask me. I would fail her because of one thing, to be honest with her. I would give her more than that. But I would fail her because she didn't ask me who is at home with you. And I came like with left.
So social history is very important. So again, she was missing or omitting some important things. I agree. What about the differential diagnosis? She told you he is most likely having TIA.
Yes.
Is that what she said? And the differential, she didn't say differential diagnosis.
Yeah, she mentioned multiple sclerosis.
Which is unlikely.
Yes.
Unlikely. Yes, he is 52, but it's unlikely. Especially it happened a few before and it recovered fully. And now another, it is in the differential diagnosis, but it's not full. Number E, what did you give her?
She asked about potential vasculitis. She asked about joint, skin, or some, but she didn't mention it in the differential diagnosis.
Yes. So anyway, that is not, I mean, this exam is very for a specialty doctor. It is not 6th year or 4th year. It is MRCP. So they need to be very, of course, this is the first time. I should not criticize because this is the first time. That's what we aim. And they should know that they should practice and come with ready-made answers for each scenario, which is commonly used. Another thing she returned back in the discussion, so I think Rand is very good doctor to be, I'm sure she will pass her membership easily. She's been using some jargon point, which we should avoid very much in this exam, like palpitation or CBC, something she said, something else. So
BP,
avoid BP, yes, or palpitation. These jargon points, which is used by us when we day to day, very easily, we use it in the hospital, but not in the exam. We should, especially the patient, they are all laymen, they don't know. Another thing is the F skill, which is dealing with patient's concern. Yes, she was very much listening to him. She told him that I will refer you to the nerve doctor, and he asked her and she explained in a very relaxed way, not like very firm, nice way, because this is all time limiting. She had only 5 minutes to answer all these questions, and I think she took about 10 minutes to answer. And it is the duty of the examiners to ask in each skill and give them the time to answer it, because if we don't go to that and the time finishes and the bell ring, that means we will give them a score 0 in that skill, and they will lose a lot of money, a lot of grades. So our duty is to control the time very clearly and ask the questions to answer all these skills and explore their knowledge in this. But in general, Rand did very well, and you've been very good examiner and surrogate. So thank you.
Thank you so much. So next we have Dr. Muhammad Umar, kindly in short because we are time limited.
Thank you very much. Good evening, all. Thank you, Ustad Wathik. Very nice session, as mentioned by Ustad Hilal. Thank you, Dr. Just sometimes some questions come to mind. For example, in your scenario, you say 52-year-old man with left arm weakness, but some dysarthria. So this mean what? Mean there is a lesion in the right side, which is not the usual side for the speech center.
So she didn't, sorry if I can't, she didn't ask me, are you right or left-handed?
Very good. So
yeah.
Here, this is, will be very interesting if she asks, are you left-handed or right-handed? So I am sure the examiner will take this point in consideration, mean that she understands the scenario in more detail. The other point, when you say she asked about alcohol and you say occasional, is it enough or need to go further for the type of the drink or amount of the drink? You know,
Yes.
the drink, not like smoking, different drinks has different concentration. Is it better to ask about detail of type of drink and amount or not?
Yes, yeah, I would say yes. But as you know, sometimes it could be tricky to ask about alcohol. Some patients not telling you the truth when it comes to
Exactly.
alcohol consumption, to be honest with you. But if you are asking politely and explaining the question and the reason behind the question, as Dr. Rand said, but Dr. Rand said it very well, but you don't have to say, I am sorry. You have to say confidently, I am going to ask you a few questions. And there are a few reasons beyond what I'm going to ask you. Is that okay? And he would say, okay to you. Don't say sorry, but yeah, I said my father passed away. You said very good, very well said. I'm sorry to hear that, but you don't have to say sorry. So I am sorry. I have. Don't be hesitated to ask good questions, and you have the reason beyond asking these questions. Say it confidently, clearly to them. I'm going to ask you a few questions. Could be personal questions, but there are many reasons or a few reasons beyond these questions. Yeah.
Thank you very much. This is what exactly we teach our students in undergraduate and postgraduate. But the most important thing is the matter of practice. And as you say, some organization, systematic way of approaching. Sometimes you may miss, but if you go systematically, I think you will be better. Thank you again.
Yeah, thank you, Doctor. Thank you for the comment.
Thank you. So finally, we will take Dr. Zainab and then go back to the next scenario. Please go ahead, Dr. Zainab.
Yes.
Hi, sir. Can you hear me? So just a quick feedback to Dr. Rand. First of all, thank you, Dr. Rand. It's very brave of you. Sorry, can you hear me?
Dr. Zainab, the voice is a bit noisy, so can you just
hear me now?
Yes.
Hello? Yeah.
Yes.
Okay, so Dr. Rand was very brave. This is a heroic action that you did tonight, that to volunteer to be the first one to be a candidate. So excellent. I liked your introductory question, which was an excellent open question to approach the patient problem, and you acted appropriately to the verbal stimuli the patient tried to mention, like the passing of his father, which was an excellent show of empathy. I would just say an areas to improve, as they Dr. Dhikra mentioned and Wathik, just avoid medical jargon. For example, the sensation, it wasn't very clear when you said sensation, so you just need to be specific. Do you have any numbness, any tingling in your leg, any balance problem is not very clear to the non-educated patient, and you can't always guarantee that your patient will be an educated person, so be specific. Do you have any gait problem? Do you tend to fall frequently? Do you have any issues in maintaining like a normal gait or a walk or a balance without having any issues? Make your questions very clear, very specific, direct and simple, using a very simple language to allow the patient to understand them, and not having to ask you frequently, what do you mean by this? What do you mean by that? Importantly, of course, with the time problem that we all mentioned, the time management, so that you need to practice more to ask a specific question which are relevant to your present complaint, so that you don't forget the social history, occupational history, and address the important issues related to your present complaint. Lastly, and the drug history, please, for all scenarios, don't forget to ask about recreational drugs. It's a sensitive question, so you need to give the patient a prompt that you're going to ask a sensitive question that is important to help you aid you get to the diagnosis. So do you use any recreational drug like cocaine, for example, which is relevant in this scenario, TIA or neurological weakness? Yeah, of course, I mean, when time allows, you need to make sure you cover all relevant histories. And presenting your case, try to summarize your scenario in a 45 to 60 seconds, so that you allow more time, to show that you are summarizing your case, mentioning the important negative, important positive, and relevant past medical history and drug history and social history, and avoid the non-relevant stuff, because the examiners were there with you, they hear the whole history, so you don't have to repeat it all over again. And as Dr. Wathik said, when you present the investigation and management, be systematic, divide them into bedside, lab, imaging, and social approach. Please don't forget, it's called the biopsychosocial approach when you manage a patient, so that you show that you are having a holistic approach and not only covering one particular thing and require prompting for the rest of the elements of management. It's a holistic approach of management that needs to be covered in a full. And thank you.
Thank you so much, Dr. Zainab, for your nice comments. So I think Dr. Wathik has left the session. Dr. Hilal?
Yes, I couldn't see Dr. Wathik. Probably there's a disconnection. Dr. Zainab, I'm asking you.
I think he's rejoining again. I think he lost his connection.
We thought that only here in Iraq where we will lose connection with the bad internet. Probably it is in UK as well. Now Dr. Wathik joined us again. Sorry, Dr. Muhammad, because we have a short of time and want to start the second case scenario. Okay, Dr. Wathik, shall we start? Because we are...
we're supposed to be doing 3 scenarios. So we will try our best and we will see. Yeah, we will see. Yes.
Yes. So the candidate is Dr. Amir Ali.
Yes, Dr. Amir. Yeah. So the second patient, a female lady, a female patient, aged 55, presented with cough. She was referred by the GP because of cough and raised calcium levels. She has got cough and raised calcium levels diagnosed by the GP. He did some blood tests and referred her to you. So please take history.
Okay, thank you, doctor.
Okay, take your time. You have 5 minutes.
All right. Can I just add something to the prior case?
Yes, yeah.
Yes, regarding what Dr. Ranchi is mentioning about the TIA, I think she's right. She's right, because the new guideline regarding the suspected TIA, they will not offer 2 things. They will not offer CT scan for suspected TIA only if the diagnosis is not going for the TIA. If we are only suspecting other diagnosis for TIA. So now, when we suspect TIA, we will not go for CT scan. We will refer the patient for MRI to be seen in a 24 hour. This is the new NICE guideline. And secondly, regarding the ABCD score, this is now obsolete also in regard to the NICE guideline. So I'm reading to you, do not use a scoring system such as ABCD score to assess the risk of subsequent stroke or to inform about the urgency of referral of patient with suspected or confirmed TIA. Right?
Well, so to be honest with you, in terms of CT scan, they are doing it every day for TIA. They definitely don't do MRI first, because it could delay the diagnosis, you know. So in the UK and Ireland, they do the CT brain. I think in many of hospitals. I'm not sure about what is the newest now, but and I think Dr. Bikra could confirm or not. Are
So
they
that
doing
maybe in the practice,
screen or-
this is
yeah.
Maybe in the
In the
practice it is
practice,
different, but
yeah,
yes.
yeah.
I'm
So-
I'm sorry to interrupt. They do CT scan to exclude hemorrhagic stroke in order
Yeah.
to start aspirin.
Yes,
and
the
ABCD
first test. Yeah.
And the ABCD score, I recently passed part 2, and they were saying it is not used anymore. That's why I didn't mention it.
Okay. Yeah. No
Maybe
harm
the
to do.
practice is different. Yes.
Okay, perfect. Yes. So yeah. So you have 5 minutes now to
All right.
start. Yeah.
Can I ask question while
Yes.
and,
Yeah.
Dr.
Yes. Go
Ayman
ahead.
sharing? Regarding vasculitis as a differential, he didn't have any positive symptoms of vasculitis in order for me to put it as a differential.
Yes. Yes. Yeah. I told Dr. Dixer, yeah, you ask about negatives, skin rash, joint. I can't remember if you asked me about eye symptoms, to be honest with you.
I said
You asked
vision.
about vision, yeah.
Yeah.
Yeah, but not red eye and these things in keeping with any like vasculitis, you know.
Yeah.
But you didn't mention it in the differential diagnosis.
Yeah, because there wasn't any negative positive. And
Yeah,
I mentioned
as
MS.
I have said to you, it doesn't, if one of the patients doesn't have, it doesn't have to be full house. Do you know, full blown picture of everything? That's the medicine, unfortunately. It's
Yes.
not mathematics, it's facts.
Yes, and MS, yes, it is unlikely. I mentioned it just because the symptoms are on and off, maybe relapsing, remitting, but of course it's unlikely, yes.
And there's very important thing in terms of stroke and TIA. You have to assess the functional baseline of the patient.
Yes, I was going to, but after
Yeah.
the social history, but I couldn't have time to like.
Yeah. So
his
next time
mobility
you will
job.
be, I'm sure next time you will be much better. And you have to ask me about who is at home with you, because if I'm living alone and you let me go home and I could die at home.
And driving as well, I
Yes,
want.
driving, exactly. Occupation. Yes, if
Yeah.
I'm taxi driver, as we have mentioned.
Yeah.
So yeah. And if you are going to advise me against driving, you have to find a practical solution for that, for my living, you know.
Yes.
You don't have to me stop driving and you don't give me the solution.
Okay, so what would be the solution in this case?
I don't know. A good question, but I don't have the answer.
Okay, thank you so
Yeah.
much, Doctor. I
I
learned
think
a lot.
Dr. Hilal could tell us like what would be in Iraq. It could be social in Iraq. If they have family support, they can support him like few weeks, whatever they until they reach the diagnosis and treat them out.
Okay, thank you so much. A
You're
pleasure
welcome.
to meet you.
Not at. Not at all.
Okay, I'm ready, Dr.
Okay, perfect.
So should we start?
Yes, go ahead.
Okay. Hello, good evening.
Good evening.
My name is Dr. Ali. I am one of the doctors here in the clinic today. Can I confirm that, I'm sorry, I didn't get the name of the patient.
Ali. My name is Ali.
Okay,
Yes.
female patient, you said. Okay.
Sorry, yeah, Salwa.
Okay, can I confirm that I'm speaking to Mrs. Salwa, 55 years old?
Yes, speaking, yeah.
Nice to meet you, Mrs. Salwa. So, Mrs. Salwa, we are here today to discuss some of the recent symptoms that you have been dealing with. Would that be okay with you?
Yes, of course, yeah.
All right, so I have been briefed by your GB that you have been dealing with cough. Would you like to tell me more about this?
Well, yes, I've been having this cough for the last few weeks. Quite annoying me. Sometimes, like I can't sleep. Can't get enough sleep because of the cough, as you know.
Yeah,
yes,
I'm sorry to hear that, Mrs. Salwa. So you said it is for the past few weeks.
Yes.
Can we tell me like more specifics, like for 1 month or 2 months?
Well, for the last 6 weeks, it's getting worse, to be honest with you.
Okay, yeah. So it is for the last 6 weeks. And
yes,
prior to these 6 weeks? Okay,
yes.
Okay.
So it's like always there for the last maybe 12 months, but it was like, I could live with it for the last 10 months or so, but over the last 6 weeks is getting worse, unfortunately.
I'm sorry to hear that.
Frequent. Yeah.
I'm sorry to hear that. Must be difficult, of course. All right. So prior to this, prior to this 12 months, you've been okay, right?
Yes. Yeah. Yeah.
Okay.
Like
So,
you have, you know, sometimes I have got flu or something like that, occasionally coughing, but not constantly.
Okay, I understand. Okay, so how can you tell me about its onset? Like it started like gradually or suddenly?
No, it was gradually over a few months, and then over the last 6 weeks or so, it's getting worse.
Okay, and it is increasingly worse, like for the past 6 weeks. Okay, and
Yes.
what do you think makes it increase?
Well, I don't know, to be honest. That's why I came to you.
All right, and what do you think makes it decrease? If you
there is no specific things, to be honest. I can't recognize anything that makes it better. I tried some cough medications over the counter, but it didn't help. Didn't help at all. Yeah.
Okay, I understand. All right. So is it like, is there any associated phlegm with it?
Phlegm, yeah, yes.
Okay, it is only for like for the past 6 weeks you have been seeing this phlegm, or it is like from the start of the first 12 months?
Well, the phlegm, I would say, especially in the morning, there was like always a phlegm. Yeah, there is a phlegm.
All right, especially in the morning. Okay, and
Yes.
is it like for the past 6 weeks you have been seeing this phlegm?
No,
or
like it's
from the start?
always now. Like for
Okay.
many months.
All right, and is it increasing this phlegm like for the past 6 weeks?
Oh, yeah, I would say so, yeah.
All right, and what's the color of the phlegm, if I may ask? Is it like yellow or green?
Well, it's like yellowish. Yeah, most times yellowish.
All right.
Yeah.
Okay, and is there any specific smell or foul smell, like any offensive smell with this phlegm?
No, no.
All right, all right. Okay, is there any blood coming up with this cough?
Yes, over the last few weeks, yes, there is blood. Yeah.
I'm sorry to hear that. And regarding its amount, it's like a huge amount. Is there any associated clothes?
Not like much amount, just like the phlegm, you know. Yeah.
Okay,
no,
okay,
yeah.
understand. Okay, and is there any shortness of breath?
Yes, yeah, I have shortness of breath, yeah.
Okay, and it is only like for the past 6 weeks, or it is more than this?
No, to be honest, even like I would say for the last maybe 2-3 years, I've got shortness of, yeah, especially when I exert myself. Yes.
This is more on exertion. Okay, and does it increase like for the past 6 weeks or so, or it is the same level?
Well, I would say so. Yeah, it could be increasing. Yeah, yeah.
All right. Okay, and is there any like symptoms of any runny nose?
No.
No runny nose. All right. Is there any history of high temperature?
No.
No temperature. Okay.
Yes, no.
Okay. No. Okay. Is there any lumps or bumps in the body? Have you felt any?
Well, I couldn't recognize any, to be honest with you. I don't check myself because I don't know where to check or how to check. No, I didn't realize anything like that.
Okay. And is there any weight changes? Any weight loss or weight gain?
I don't weigh myself, unfortunately, so I'm not entirely sure.
Okay, but have you seen like your like the size of your clothes changes? Maybe it's getting tighter or getting looser?
No, it's getting looser now. Yeah, I can't.
Okay. I understand. All right. Is there any okay? Is there any chest pain?
No chest pain.
No chest pain. All right. And is there any like swelling of the ankles or leg swelling?
No leg swelling. No.
Okay. And all right. How about your appetite, Mrs. Salwa?
My well, it's not good. It's not good. Yeah.
Okay. All right. And is there any Is there any headaches?
No headaches. No, but as you know, occasionally I've got some headaches, as everyone. Yeah.
Yeah, I understand. Okay. Is there any fits or funny turns?
Fits? What do you mean by fits?
Any abnormal movements?
No, I'm not shaking. No.
No shaking. Okay.
No.
All right. All right. Okay. Is there any problem with the balance? Maybe any steadiness or something?
No. I
Okay.
feel okay when I walk. No.
Okay. All right. Is there any problem with the swallowing?
Well, my swallowing, I would say it's okay. The usual.
All right. All right.
Sometimes,
Any
yeah.
soreness in the mouth?
No.
Okay. Any like tummy pain?
Tummy pain? No, tummy pain.
No tummy. All right.
Well, to be honest, occasionally I've got some tummy pain. Yes. Yeah.
Okay. And can we be like a little specific in which time of the day maybe, or it is related to
Well,
specific
there is
food?
no specific time during the day, but occasionally I've got some tummy pain.
Okay. And is it like in the center of your tummy? Is it like generalized?
Yes, yeah, I would say in the center of my tummy. Yeah.
Okay. And does it stay there or does it spread to any other parts? Like in the
it's
back?
just, in the center of my tummy.
Okay. And all right. And have you noticed any like swelling in the tummy?
No, to be honest, no. I have noticed, as you have said, like loss of my weight, as you know. So
okay. Any change in bowel habits? All right. All right. Any change in the bowel?
Yeah, I have noticed recently I've been more constipated. Yes. Okay.
All right. Yeah. More constipated. And this is like unusual for you?
Yes. Yeah.
All right. Okay, understand. So have you noticed any blood coming up from the back passage?
No, I didn't notice that. No.
Any black stool?
No.
All right. Do you have any problem with your water work, Mrs. Salwa?
Well, no pain when I pass. No pain or stinging. No.
Okay. Any decrease or increasing in the amount?
Well, I have noticed I'm going to the toilet more frequently, as you know. Yeah. So more frequent I'm going to the toilet.
And for how long you have noticed this?
Well, to be honest, I can't say for how long exactly, but maybe over the last 2-3 months, I would say. Yeah.
All right. And regarding this amount, is it increasing like every time you have been going to the toilet, or it is decreasing like with the frequent urination maybe?
No, it's more frequent.
Okay. And does it change in color? Is there any change in the color of your water?
No change in color, but in terms of frequency, I would say it's more. Yeah.
Okay. All right. And you said you don't have any pain like when you go to the toilet?
Yes. No. Yeah, just
okay. All right. And is there any increase in thirst maybe?
Yes. Yeah. I have noticed. Yeah.
And this have been going on like with the same time you having increased this amount of urine?
Sorry, could you repeat the question?
And you said you have getting more increase in thirst, and this is like at the same time?
Yes, yeah. Over the last 2-3 months, I have noticed that I'm drinking more, passing more urine.
Okay, understand. And what about your mood, Mrs. Salwa? Is there any change in mood maybe?
Well, to be honest, I have noticed that my mood is not good. I have some low mood occasionally.
Okay, I'm sorry to hear that, Mrs. Salwa.
So now we have about 11 minutes. Yeah, so you have 3 minutes just to warn you.
All right. Okay, and can you tell me more about, is there any back medical history I should be aware of?
Do you want to ask me about a few things specifically?
Okay, do you smoke, Mrs. Salwa?
No.
Okay, you don't smoke. Okay, and do you drink alcohol?
No.
All right, and is there any family history of note?
Well, my mother passed away because of breast cancer about like 1 month ago.
I'm sorry to hear that, Mrs. Salwa. All right. Okay, and is there any pets at home?
That's no, I
All right,
don't have.
and okay, and have you traveled recently?
Traveled. No.
Okay, okay. Can I ask you, what do you do for a living?
I am a housewife.
All right, okay.
Yeah.
And all right, and do you have any drug history? Can I see your drug list?
What do you mean by drugs? I'm not a druggie.
I'm sorry, about medication. Are you taking any medication at the moment?
No, just some like vitamins occasionally.
All right, and you don't have any drug allergy?
No, not something I am aware of. No.
Can I ask you some personal question, Ms. Salwa?
Yes, yeah, go ahead. Yeah.
All right. Okay. Are you married?
Yes.
All right. And are you sexually active? Sorry. You said you're married. Okay. And do you take any pills? Any like contraceptive or pills?
My
Birth
age
control
is
pills.
55. The horse has bolted. Yeah.
I'm sorry to hear that, Mr. Salwa. Okay. Yeah. All right. And all right. And okay.
So you have
do you
1
drive,
minute.
Mrs. Salwa? Do you drive,
No.
Mrs. Salwa?
No, I don't.
Okay.
No. You have
Okay.
1 minute.
Okay. Yeah. So can I ask you, Mrs. Salwa, what is your concern?
So what is worrying me, to be honest? I don't know what's going on, because it's for many months now. I'm getting worse, not better, unfortunately. So can you tell me what's going on, please?
Yes, Mrs. Salwa. So, Mrs. Salwa, regarding from our discussion, first I need to examine you, of course, but from our discussion, I believe you have a condition, we call it bronchiectasis, so which is basically an irreversible dilatation of the air sacs inside our lungs. And okay. This, I think, what is leading to your problem now. And regarding this increase in the symptoms recently, I'm really worried about another thing. We call it, maybe it is a lung cancer. I'm sorry to hear that. Yeah. Are you with me, Mrs. Salwa?
Yes, yes, yeah, I'm listening. Yeah.
That's why we will do some blood tests, and we will do some some scan of your chest in order to make sure of our diagnosis. And then we will have another sit down to discuss about the result of investigation. Yes. How does this sound to you?
Yeah, okay, yeah.
All right.
So, yeah, the time is up now. So, yeah. So, what do you think?
So,
take 1 minute to reflect, summarize what you are going to say, and we will discuss things. Yeah, very good. Thank you. Yeah.
Okay, I'm ready. Hello?
Yes, yeah, go ahead. Yes, yeah.
Yes. So, do you want to ask me? I'm sorry. Should I present my case?
Yes, okay. Yeah, please do.
All right. So we have Mrs. Salwa, 55 years old, presented with an increasing cough and sputum production. Her cough, it is like for the past 12 months, but her cough has been increasing like for the past 6 weeks, and associated with the production of large amount of sputum, especially at the morning. And this is of a greenish yellow sputum associated with the blood. And the patient reported also been decreasing appetite and weight loss. And there is also some other symptoms. As patient have abdominal pain, low mood, and polyuria and polydipsia. And I'm concerned about this maybe due to hypercalcemic symptoms related to an underlying malignancy.
Okay. So what would be your differential diagnosis now?
So my differential diagnosis could
from
be
at the top of the list. List them at the top of the list and down.
All right. So it could be bronchogenic carcinoma. This is number one differential diagnosis now. And another thing, this could be also sarcoidosis, although the patient didn't reported any history of fever or lumps or bumps, maybe. Or another thing, the patient could have a long-standing history of either interstitial lung disease or bronchiectasis, and this would be like the baseline, maybe lung disease, and this could be superimposed by bronchogenic carcinoma now.
Okay. So what would you do for this lady?
So regarding presentation now, I will not admit the patient, but I will do some of the investigation in the form of complete blood count, looking for anemia and leukocytosis. And another thing I will do ESR and C-reactive protein as inflammatory markers, and liver function test to know if there is any liver involvement maybe, and the renal function test as a baseline function, and also electrolyte, potassium, sodium, and especially serum calcium, although it was done by the GB already. Another thing, I also would do a chest X-ray and a CT scan to look for an underlying malignancy. And also maybe if there is positive, maybe the patient will need an appointment for bronchogenic, for a lung biopsy. Another, if it is came positive, there will be another request for CT staging, CT abdomen and pelvis. If it is came positive, I also would run a pulmonary function test to look for if there is a restrictive or obstructive pattern, because the patient have a long-standing history of respiratory illness. I will do also a full lung study, sputum study, to send for analysis and fast bacilli and culture. I will also do arterial blood gas analysis to look for any derangement. All right.
Yes, go ahead.
All right, okay. And after these investigation, of course, the patient will be referred to a multidisciplinary team. This will consist of a pulmonologist and
So so I think time is up now. So thank you so much, Dr. Amir, for your help, and you are very good. But let me do my brief comment, and I think Dr. Al-Wattar would be more helpful in terms of assessment. So when I asked you, when you asked me, do you smoke? I said no, and you didn't say, have you ever smoked? I'm smoker for 30 years now, and came to you with weight loss and hemoptysis and loss of appetite with significant history of smoking. And when you told me about the possibilities, you have to say to me, we are talking about possibilities here, but we need to do a few things to confirm or rule out a few these possibilities. You mentioned bronchiectasis the first to me as a patient. Have you? Yeah. Did you mention bronchiectasis?
Yes. But then I told the patient, but now regarding like for the previous respiratory illness, but regarding these 6 weeks, I'm worried about another thing. And I told the patient, I'm worried about lung cancer.
Well, to be honest, lung cancer could be medical jargon, as you know.
Medical jargon? So
it could be like, it could be scary to the patient, as you know. And when you, I am not saying in this station you have to be, you have to explain it sensitive, because there is no time for it. Could be in ethics when you break bad news. We need to be more sensitive when you are saying to the patient, one of the main possibilities here, we are talking about cancer in your lung. It could be disastrous to the patient. When you say it, try to, there's something called golden silence, you know? So when you say something scary to the patient, you have to stop talking for a few seconds.
Yes, that's why I stopped and I asked you, are you with me, Mrs. Salwa? And you said yes.
And I said, yes. And you continued like to talk, but you have to say to me, are you happy to carry on Do you want us to carry on, or shall we talk later maybe?
Yes.
But you are very good. When you missed the smoking, did you ask me who is at home with me?
No, no.
Yeah. And in terms of medications, when I said vitamins, it could be vitamin D, no? It could be vitamin D. Excessive vitamin D I'm taking and causing. I know like the history could be like very clear, consistent with malignancy associated hypercalcemia. Yeah, and in terms of differential diagnosis of hypercalcemia, what are the main causes of hypercalcemia?
So if we are not talking about this case, I would say if it is like due to hyperparathyroidism, due to hyperparathyroidism, and if it is not due to hyperparathyroidism,
Yeah.
like if it is due to PTH related parathyroid hormone, we have maybe primary or like tertiary or pseudo hyperparathyroidism.
But in this lady, well, the most.
But in this lady, yes,
yeah.
of course, I will be concerned about bronchogenic carcinoma.
Okay,
And mostly,
malignancy associated hypercalcemia. And what are the other like possible causes of?
yes,
respiratory
sarcoidosis.
Hyperparathyroidism. Yes. Yeah. Sarcoidosis, you didn't ask me about any skin rash, any joint pain, any eye manifestation, because all these could be manifestation of sarcoidosis, as you know.
Yes.
But you are very good. You ask about polydipsia, polyuria, abdominal pain, all symptoms of yeah, and when we are talking about possibilities, say to the patient, here we are talking about only possibilities. There are like some possibilities at this stage. I'm not entirely sure, but we are talking about possibilities. You can say something and with the investigations could be not true. And the patient could kill him or herself when you said to them, I have cancer, you have cancer. Okay, yeah, thank you so much. I think and Dr. Wathik, if she's happy to comment, we would be grateful for her.
Yeah.
Okay, thank you so much.
Okay, shukran. Dr. Ali or Dr. Amir? Is it Dr. Amir?
The
Dr.
patient
Amir,
is
yes.
Ali. The doctor
أنت
is
Ali,
Ali.
بس the patient, the candidate is Amir. Okay,
Yes.
just to say that excellent doctors and those who are very clever and the best clinician, they may fail this exam. This exam is an art to answer, and it's a skill to develop. فأني اللي شفته من الدكتور, he is very efficient doctor, بس يعني اسمحوا لي راح أني أحكي بهالطريقة. One has to be very systematic, not to jump from one thing to another. يعني بالدماغ لازم يكون كل شيء in sequence حتى you don't miss any of the information you take, especially in someone who has a long-standing cough, dry cough, and he's been heavy smoker, lifelong smoker. We need to know how many cigarettes a day and for how many years he's been smoking. And yes, you asked about weight loss, which was very good answer, and it was fine to know what is. It's very significant. I didn't know whether there was any question about having hemoptysis or not, but maybe you asked and I wasn't.
He asked me about hemoptysis.
Hemoptysis is very important.
Yes.
Then when you asked, when it came to the telling the patient what is going on, he said, I think you have a bronchiectasis and you may have cancer, and these are not acceptable to say it that way to the patient. As you mentioned, Dr. Wathik, we should show some empathy when we say whatever, because whatever we say, it's all counted. Yani it's not acceptable to say, especially it is not right. I mean, how do you know this is a bronchiectasis? You did not elicit any history of a large amount of phlegm, history of pneumonia as young child, or history of bronchiolitis when you were very young. يعني ماكو فد evidence يخليك تفكر إنه this is a bronchiectasis. وحطيته number 1. Number 2, yes, it could be cancer, and the cancer can be bronchogenic carcinoma, but could be other cancers. ليش مو multiple myeloma مثلا and وياها مثلا shortness of breath أو metastasis؟ لأنه high calcium, weight loss, ما راح على bone pains, ما راح على other things which can direct him into the causes of hypercalcemia. This is what I say. In the letter given by the GP, he was given very good information. إنه he had a chronic cough and hypercalcemia. It could be drug-induced. He may be, although he is young, but maybe he is on supplement. Every one of us take a lot of vitamins every day, including calcium. I thought, yes, Dr. Amir was very good, but I think still lacking the skill of having good structured and systematic history taking, and also the differential diagnosis was not very appropriate. And of course, whenever we get the diagnosis wrong or probable diagnosis is not appropriate, the skills of arranging investigations will follow because it is linked. I cannot accept this, and when he say I will do CT scan, will be acceptable. You know, there are certain skills which are linked to the other ones. So whatever we say as a diagnosis, suppose I say this patient will have interstitial lung disease, I will not mark him full if he say I will do HRCT, because the diagnosis is wrong. This is not interstitial lung disease. And this is unlikely to be sarcoidosis because number one, in the history, we did not get any information that this is sarcoidosis. Even a simple chest X-ray is not done to show whether there are any changes or hilar or whatever changes. So on this occasion, this history, in my opinion, was unsatisfactory score. Despite knowing that it could be cancer, it could be bronchiectasis, it was not very systematic. And I think if it was me examining, I will not pass this candidate. And of course, we can have a lot of differences. This is what comes. So before we see any case, me and the other examiner, we should calibrate each skill and we will agree. If they say bronchiectasis, we will say wrong and we may fail them. If they say sarcoidosis, it is highly unlikely. If they say cancer, we will put it yes. If they say lung cancer, fine. Other cancer with metastasis is 2. Investigation, again, we will agree. Again, I don't know what is the level of the calcium. I think he may need to be admitted to the hospital and have, because having high calcium is emergency. We have to admit the patient and lower it because this is very important management. So I talked a lot, maybe you can probably feedback, but in my opinion, as a case, it was not very successful. Sorry, I cannot hear you.
Thank you so much,
Yeah.
Dr. Wathik. You are very helpful and we appreciate your input. Thank you so much. So yeah,
Dr.
I think if you have time is up now. So if you like, we can do like next time 3 scenarios if you like, because now it's
we will continue the discussion because the
yeah,
time
if
is
you
up
like,
for
yeah, I am happy.
case.
But yeah, if
Yes.
everyone is happy, I am happy for that. Yeah.
Yes, so
Yeah.
we will continue the discussion.
Yeah, and
we
I
have next
would
Dr.
like to
Mahmood.
thank Amir and Rand, because without their help, we wouldn't be able to make comments, as you know. So you are very good. We are practicing, and I am sure next time you will not forget asking about smoking, addressing patients' concern, like in a better way. I'm sure you will do that. That's why we are practicing now.
Yes.
So yeah. So the next case.
No,
Yes.
we will continue the discussions because
Yes.
we will not have time for another case.
Yes, yeah, okay, yeah, perfect, yeah.
Yeah, so we have Dr. Muhammad,
Yes.
Umar.
Yes.
But also before Dr. Muhammad start to talk, thank you very much, Dr. Wathik. استاذتنا الكبيرة دكتورة ذكرى, يعني your comment were very useful and to all of us. And I think the time is limited even for discussion. So may I ask kindly Dr. Muhammad Umar and I think Dr. Rand raise her hand just to be in short in their comment.
Thank you very much for all. In short, what is important for all of our colleague candidate, this is what's called a focus history. So the scenario should direct you for specific question for that history, number one. In this case, specifically the polyuria and polydipsia, I mean excess urination and thirst, yes, they are feature of hypercalcemia, but again, differential diagnosis of diabetes should be there. She's above 50 and she has weight loss and polyuria and polydipsia. The other point, the family history of breast cancer was very important. So now she's female above 50 and mother died of breast cancer. So I don't think of that again. So in the investigation, mammography should be there. And just one question, always we classically ask, I like to ask Ustad Wathik and Dr. Dhikra, to start after confirming the patient and introducing yourself and taking permission for detailed data. The question, class one, is it preferable to ask the patient, do you like to have someone with you? I mean, you are taking history with the patient. Is it always preferable to ask the patient, do you like someone to be with you? For example, your wife or your brother, sister, someone. Is it the preferable classical question or not?
Not in this station. Usually we ask this question when we are doing station 4, which is the communication skill, especially if there is a breaking of bad news or having issues which can be difficult. Taking history is you to listen and construct a management plan in a very supportive way, rather than breaking bad news and waiting for a bad reaction to happen. So no need for someone to be with.
Thank you very much.
Yes, I do agree. Yeah, in breaking bad news, because when you are going to say do you want somebody to be with you, it's kind of a warning shot. It's kind of you are going to hit that patient with a huge thing. So it's one of the warning shots if you are saying to them to. So yeah, before going to say, you are going to say I've got bad news to tell you, which is another warning shot. Yeah, I do agree with Dr. Al-Wattar. Yes, it's in station 4, especially when you are breaking bad news. Yes.
Thank you so much. Next, we have Dr. Zainab, please, in short.
Thank you for your participation. Just a few things to comment on. I mean, this comes with the practice. When you ask questions about symptom severity, don't say what makes it increase, what makes it decrease. It's better to say what makes it better, what relieve your symptoms, or what makes them worse. The other thing, you just took too much time in trying to explore the cough history, which left you with little time with the other presenting complaint, which was in the GP's data, which is hypercalcemia, which kind of more important and more relevant to this history. When you ask about particular symptom, don't be apologetic, because you are saying, sorry, can I ask you more about hemoptysis? Don't be apologetic as long as you are polite and professional in your approach. In the drug history, the patient said she's taking vitamins, and a patient with a hypercalcemia, you need to specify what vitamins are they. Is there any vitamin D as an important negative question, and how much are they taking of the vitamin D, because it's relevant to your present complaint, which is the hypercalcemia. And when you are explaining the diagnosis to the patient, please don't say there's a possibility of lung cancer when you are not sure. And this is what the other kind speakers mentioned. Just say, we still don't know what's going on. We're going to admit you. We're going to run further tests to explore the underlying diagnosis, and we will let you know, and we'll keep you updated once we get the results. Don't say anything that is sinister or anything that carries a high emotional burden to the patient and makes them live in fear until the investigation comes back, which is possibly negative, because you put the patient under unnecessary distress until then. In this scenario, you mentioned the most likely differential diagnosis is lung cancer. Because this is a patient with a hypercalcemia, if you say lung cancer, it's better to say metastatic lung cancer or possible paraneoplastic syndrome, which is also related to hypercalcemia. So the more specific you are in your differential diagnosis, the better you'll look, the more knowledgeable you'll look and the more you'll impress your examiner. And lastly, please don't rely on GP's investigation in the scenario before you go to the patient, before you see the patient. Don't rely on their diagnosis, don't rely on their investigations, because you're seeing just keep in mind that you're seeing this patient as a fresh new patient, and whatever was referred to you could possibly be wrong. So don't rely on that, and do whatever you feel is appropriate. And thank you.
Thank you, Dr. Zainab, and very useful comments, really. Dr. Wathik, I think he's disconnected again. Anyhow, it seems that Dr. Wathik disconnected again. Anyhow,
I can't hear you. Yeah, I can't hear you. Sorry. Yeah.
Sorry. Thank you very much, Dr. Wathik. Really, it was a very useful session. For us, it was a revision for history taking and being structured, systematic, organized, and as you focused on أستاذ ذكرى أيضا إنه by repeating the scenario and history taking, we try to improve our level of performance and to make use of the comments by the distinguished examiners and professors and colleagues attending this session. Thank you very much, Dr. Wathik, and if you have any final comment, the floor is yours.
Thank you so much. I would like to thank everyone. It's all about the teamwork, and as they say, teams make dreams. So thank you.
Thank you very much, and big thank to Dr. Zainab. She was originally behind the idea of doing these sessions online, and it seems to be useful. As I see from the attendance comments, they were pleased and they were engaging in the discussion and the comments, and they contribute a lot. Thank you all for attending the session, and there are more 5 sessions to come, and please follow up our social media and website announcement on the coming sessions, which are collectively to train you for a better performance on doing your PACES in the future successfully, inshallah. Thank you all, and see you again inshallah in the next session. تصبحوا على خير.
تصبحون على خير جميعا، في امان الله.
تصبحون على خير. شكرا.
في امان الله. مع السلامه.